quickly that the regional CESA committees have been formed, or at least some of them have, and I know that Deanna and I have both received invitations to serve on the Region 1 Regional CESA Committee. And so at some point, maybe we could coordinate with Ron, or maybe it will be now with Lynn or Jody, to figure out, which mental health boards are being represented on which task force, so that we can have also better coordination at our level if we want to keep each other in the loop and organize any type of specific advocacy. Is there anybody else that wanted just to make a brief comment on anything that's happening at a state level? And then we'll just jump right into our presentation. Jody, you're muted. Do you have something?
Yeah. So I had just sent to Leanne Reinhardt last week. She had approached Ron about there were some holes in some of the regions that they knew that we had members in, but they weren't quite sure. So we sent them the listing. I believe some folks did get an email. I think Jim, you might have gotten one, but we made sure that all of the members that are in each of the regions, that they had their name and their email address, so they can contact them and send them a notification.
Great, thank you. Okay. So we actually have a lot of these meetings scheduled with presentations, so we're not going to have a lot of time to discuss things, but the January meeting is open, so maybe we might leave that one open so we can touch base and have a broader conversation about things. Without further ado, though, I will introduce Cheryl to kick this off from Oak Park, and she's I believe coordinated with one of her local providers to talk today about the intensive outpatient and crisis reintegration services in her area. Go ahead, Cheryl.
Yeah, no problem. So, often when we're talking about crisis services, we're talking about the a distinct period on that continuum where it is a person's acute crisis being responded to by either the police, the fire department, or some type of emergency response. But there are other really important areas where we can intercept individuals and potentially divert crises or diffuse crises, or prevent crises from happening again. And part of that continuum is the utilization of intensive outpatient programs and partial hospitalization programs, so IOP and PHPs. We invited Julio Sandoval, who is the Director of Social Services for the local behavioral health hospital to Oak Park, which is Riveredge Hospital. And he is going to give an overview of what the clinical model of IOP, just a brief overview of what the clinical model of IOP and PHP are. And then I'll get into a little bit more about how they can strategically be utilized when operating within a crisis continuum, and then also how 708 board specifically can help to get those more embedded into our communities. So with that, I will pass it over to Julio to give us a rundown of those services.
Nice to meet everybody. My name again is Julio Sandoval, the Director of Social Services at Riveredge Hospital. So I manage our inpatient social services team, and I also oversee our IOP and PHP programs for adolescents, pediatric populations, and adults. So kind of how Cheryl was saying is our IOP and PHP programs, I think in general are sometimes underutilized because they could serve as a means to help prevent a lot of crises, and also work in conjunction with decreasing crises after an incident. So the main difference between an IOP and PHP in an inpatient setting is, you have an individual who goes into crisis, and that's when they would get, SAS called, or police intervention, and then they get hospitalized. But I think what happens is sometimes we miss the warning signs and we miss, the steps that are leading up to that crisis. And that's really where IOP and PHP could be utilized. PHP is usually more so of a day program. Our PHP runs from 9 a.m. to 2:30. And it's very group intensive, trauma focused CBT. And what it serves is it's instead of going to school or instead of going to work, it's an intense program where an individual could go, not necessarily be inpatient, but go for the day, learn how to manage what's going on with them, and then taking that back home to their home environments or their school environments and seeing what's been working, what's not been working, and then coming back the next day and reporting the therapist or to the groups as to, I went home yesterday after PHP and I still got upset and I noticed this coping skill didn't work for me. What else can I utilize? Similarly, our IOP program, that's a program that's from 4 to about 7, 4:30 to 7:30. And that's a shorter amount of time. It's less intensive. It's less structured, but it still serves as a means to help support individuals in reaching their goals in not a structured setting, so to speak. They still have some structure and still group heavy, but they're utilized as a means to support. Or maybe I could use this IOP program in conjunction with my individual therapist to help support me in reaching the goals that I have. So they serve as really great prevention programs. Sometimes parents aren't too keen on having patients hospitalized, or honestly, patients meet criteria, but they still need a lot of help. These programs are utilized to help support individuals and not going through that crisis moment. Similarly, they are used as a means to help integrate back into the community. So you have an individual who went through their crisis, who did their hospitalization, who's learned the coping skills, who's learned the communication skills. But the real test comes from when they get out of the hospital and try to go back to the community, meaning going back to school, going back to work, going back to their everyday lives. I mean, one of the things that we tell individuals here is that, your stressors are still going to be there when you get out of the hospital. It's a matter of how you plan to manage them and how you plan to work through them. And with PHP and IOP programs, in conjunction with traditional outpatient services, studies show that the recidivistic rate of coming back to the hospital is a lot lower than patients who don't continue with those programs. Again, they serve as great check-ins for returning back to the community and then checking in with your program to see what's been working, what's not been working, and really catching if you're even able to. I mean, if you were truly stable to be discharged from the hospital. Again, they work in the same ways as they do for the preventions aspect of things. They serve as a way to kind of prevent relapse back into rehospitalization. And they're flexible. The programs are flexible. So with adolescents, we do, as long as schools are okay with it, we'll usually do like a hybrid program of maybe PHP Monday, Wednesday, Friday, school Tuesday, Thursday, or vice versa. Just to kind of, again, help them reintegrate into that setting. Because again, their stressors are going to be there. It's just a matter of how we're going to face it head on.
Are there any questions for Julio about the actual clinical model, and what are people clear on what IOP and PHP look like in a practical application? Looks like, yeah.
Hi, this is Leon. I'm just questioning, are there any summer programs available for either the IOP or PHP programs?
So our PHP and IOP programs are year round. They are in session during the summer. The only times that we'll have PHP or IOP off is national holidays, but we run through the summer. And in the summer, we actually, because it's a lower census, we're able to accommodate a little bit more. So we'll be able to, a lot of times, open up different tracks to focus on specific needs of the community. So our PHP and IOP were able to be flexible, and so sometimes we'll do an all depression track versus an anger management track. Really just based on what schools are letting us know that they need or what's, what trends they're seeing. I know in the past we've done a track for school refusal, which I know is a big one. We've done depression, anxiety, anger management. So summer allows us to be a little more flexible. And I mean, our individuals that we serve are flexible too, because they're usually not in school every day, or not their busy 9 to 5.
Thank you.
So one of the reasons we wanted to bring this up is because, like I said, we're talking about a community of practice when it comes to crisis response and building up crisis services. And I think that when people think of mental health services, they generally think of either some type of psychotherapy or some intermittent therapy services or hospitalization. And there's really not much consideration for IOP and PHP, which fill that intensive but not acute care model. And we are seeing, in part of the conversations that we're having here in Oak Park are that we do need to utilize those services in a much more thoughtful and intentional way. So, Julio talked very well about the trajectory. So for someone who has been hospitalized, coming out of a hospital situation and that intensive acute situation, going into something that is still a little bit more structured, a little bit more intensive, more attention focused on that person through IOP or PHP does help with that transition. So that it's not just released from hospital back to your regular life. Especially for individuals who may only be seeing a therapist once a month or even once a week for an hour isn't quite adequate to meet their needs. These programs also offer the ability to do a more intensive medication management because there is psychiatry consultation that goes along with IOP and PHP. So for example, if someone's medications were changed during that hospitalization, or if someone was taken back down the baseline and is starting a new regimen, when they're released, that allows for the psychiatrist to stay and monitor in a more regular way. Almost they're clinicians looking at the person almost on a daily basis and can flag if there are any signs or symptoms of that should be concerning to the psychiatrist. And so the attention is very helpful, and you can go from inpatient to partial hospitalization program to intensive outpatient. So especially, we talked a little bit about students, but also people who are working. That way they go back to work or they go back to school, but then at night they still have a support structure in place through IOP. And then eventually, hopefully, maintenance therapy, psychotherapy is what they would need to keep moving forward, or maintenance psychiatry. But the IOP and the PHP can also help in that. So that's the step down approach. But I think they could be better utilized, and are in some cases, to be a diversion from the step up. So there are options for if someone is involved in if someone is seeing a therapist on a regular basis, and there are some stressors that are starting to make someone's symptoms heighten or get into a more acute state. I keep saying the word acute, but as they go up, that ability to intercept them and say, hey, you might need an IOP program, you might need a partial hospitalization program. Let's try these out for you so that it's not, 2 a.m. on a Saturday night and you are having suicidal ideation and we have to call the police and you have to go into a hospital. So utilizing those programs to help support and surround the person with resources before it becomes an acute state. And I've used this example often. So if you've heard me say it before, I apologize, but I used to, in my early career, I worked in HIV services in the mid-90s. And at that point, the traditional course of treatment was not to introduce medications until a person has an AIDS diagnosis. What that resulted in was poor health outcomes for that person, sometimes including like losing that patient. It also was an increased cost. And it wasn't applying the public health interventions in the most effective way. And so for all people involved, it was a bad course of treatment. And we learned from that pretty quickly. And then it was, no, you introduce therapies when the medications got better. Then we found you introduce therapies from the very beginning because it helps to increase that person's health outcomes in the long term and reduce the acute symptoms. And so essentially, while this isn't, we aren't prescribing, well, in some cases we are prescribing pills, but the IOP and the PHP can help play that role where you introduce it if you're starting to see that someone is going to experiencing a crisis as opposed to waiting until they're there. So in Oak Park, one of the things that we're doing is so we work very closely with Riveredge, and we are also working with a community hospital here, it's like our safety net hospital, West Suburban, as well as our counseling center, Thrive, and trying to figure out where the gaps are in those services and build additional IOP and PHP programs. So specifically with Thrive, they are working right now as it's a co-responder light model with the Oak Park Police Department. So if there is a mental health crisis, Thrive Counseling Center is called. They have a crisis person who goes out and is able to help with the situation, de-escalate, get someone into hospitalization if they need to. But they're sort of our person right now. And that model has been in effect for 35 years. So we're at the point now where we're doing some evaluation and we might be tweaking it a little bit more. But right now they're the ones who go out. But what happens is because they are only a counseling center, I put it in quotes because I don't want to minimize the fact that they do that service because it's important. But what happens is they don't engage with the clients after hospitalization, because those individuals need to step down into an IOP or a PHP, and they don't provide that service. So right now we're looking at how do we make sure we're not losing people along that continuum, and how do we make sure that there's relationship building. And so we are having conversations about them starting up an IOP or a PHP, and the 708, as the 708 board, the role that we're playing in that is that we can help provide the investment into developing the program that will eventually be able to build commercial insurance, Medicaid, and so forth. But to build that program and to give them that on-ramp, that's where our money and our investment would come into play. And so it is identifying that need, as well as helping to fund and get that up and running. So, we wanted this to be not so much us showering you with information, but putting some information out there about what the programs are and the role they play. But I'm also just curious to know how you guys are utilizing IOP and PHP, or are you including that in your strategic plans to build up as a part of your crisis response models?
Thanks, Cheryl. I'm not responding to the answer to your question yet. I'm gonna process that, but I have a question for you, which is, so I love the vision for IOP and PHP being utilized as a first intervention or like a prevention to inpatient hospitalization. Also aware of the fact that a lot of people enter the mental health services for their first time in a crisis event. So
True.
while therapists and psychiatrists might know those cues to say like, hey, here's a good point where IOP might be appropriate. Let's prevent this from becoming a crisis event. What would be some of the other, I guess, ways that somebody can be referred, or maybe like how else would somebody get into this program? Either through partnerships, just like a primary care physician's office, or is there other type of education and advocacy that can be done, or awareness building around when somebody is experiencing their first mental health episode, that this is an option, and especially if there's wait times to get into a traditional therapist or something like that, so it does not escalate into a crisis event that requires inpatient hospitalization.
Yeah, it's a great question. I have a couple ideas, and then Julio, I'm sure you have some ideas on that as well. When it comes to youth, our schools make a lot of referrals. So they're doing different levels of intervention and looking at, I mean, I don't know the exact language that the schools use, but basically like behavior infractions that would escalate to this, and they're making referrals into IOPs and PHPs. In addition, we have for our Infant Welfare Society Children's Clinic, they do behavioral health screening assessments at every dental visit and every well child visit. They're our local they're called Collaboration for Early Childhood. They're doing trainings with daycare workers. And then for adults, we're seeing some referrals that are coming from living room programs where they don't, again, it's a diversion program. So people, are escalating, and they, in a living room program, they might actually be in a crisis that is resolvable through the staff at a living room. And then their step down program would be, so it's not quite a step up program because they're still kind of in crisis when they get to a living room program, but for adults, it's a good referral mechanism. Julio, I don't know if you have additional thoughts.
Yeah, I was gonna say, I think specifically for adults, I was gonna say that the NAMI living rooms have been a good resource, as well as SAS has now started to work with adults, a lot of SAS agencies, and so they will assess a patient or an individual and then refer them to our IOP or PHP programs. A lot of our referrals do come from schools for adolescents and pediatric populations. The majority of them are from schools, but also from local PCP clinics or local doctors. I think again, it is an underutilized resource. I don't think a lot of people know that it exists, but it is a way to prevent some of the hospitalizations. And I mean, it's also the majority of hospitals that provide IOP and PHP, they are walk-in hospitals, so 24/7 assessments. You would just come in and I know from Riveredge, you would come in and do something what's called a level of care assessment. Once they do that assessment, they'll tell you what program you're more fit for, IOP or PHP.
Jim has a question in the chat. Will Medicaid pay for the diversion service or just the step down? That's a really great question. I don't know the answer to. I don't know if you know, Julio.
Yeah, so Medicaid, again, depending on what hospital, I know for Riveredge, Medicaid does pay for both services in both ways. So if we could have a patient who starts in IOP who needs more support, so we'll transition them to PHP, and then an event happens in PHP, we step them up to inpatient, and then we'll step them back down to PHP and to IOP. As long as there's a need for it, and it's rationalized and it's an appropriate step down and step up, Medicaid will pay for all of the services. It does require utilization management, and we do have our own utilization management teams. So our teams will contact insurance companies, request more units if needed for those outpatient programs.
So
So this is, oh, sorry. Go
oh,
ahead,
yeah,
Jason.
no, go ahead, please.
So this isn't really a question, but it's kind of a comment, and I'm hoping maybe there's a little discussion here. So our PHP IOP program opens next week on Monday. Northwestern Medicine has added that to our programming out here. We have an interesting situation because Northwestern Medicine owns our hospital, our community mental health program, our police social work liaison program. Like they're kind of the big player here. And so it's really what we're really interested in paying attention to is just kind of the evaluation and feedback of what this is going to look like. Right now, we're really just trying to get the word out that this is starting. This is something that's completely new to our community. We also do have a living room, also run by NM. We're starting adults on November 28th, and adolescents are going to come in March. And so just any thoughts or comments you have about the evaluation piece, like how do we know that we're reaching who we need to reach and doing what we need to do? And we know there needs to be flexibility with this program. We don't know what we don't know about it yet. And so just any like maybe things to kind of keep an eye out for.
Pass that one to Julio because you probably do evaluation of your programs.
Yeah, I think, I mean, starting a IOP and PHP program, I think for the biggest, one of the biggest obstacles you'll probably face. It may be different for Northwestern because you guys will probably feed a lot of your admissions through your departments, through other departments. But the attendance rates, making sure that a lot of insurance companies will require at least 3 days of programming in order for them to cert the stay for the IOP and PHP programs. So attendance rates is a big one. I like to think that for PHP and IOP, you need a little bit more than your traditional talk therapist, because that'll only go so far. You want something that's going to set your programs apart from just traditional talk therapy, because a lot of these individuals do want to get back into the swing of things in their lives and go back to how things were. And so a lot of them will be hesitant to attend programming. So we like to utilize, we utilize talk therapy. We also utilize a lot of music therapy, drama therapy, creative arts, our creative arts department. We utilize them a lot to support in the programming of IOP and PHP. But I don't think you'll have to worry about your admissions.
It would also be interesting, since it's a brand new program, looking at your current hospitalization rate and readmission rates and comparing those to post, comparing it to the small pool of people who will be in PHP IOP. If there is some way, I mean, if it's Northwestern, they should be able to have pretty robust evaluation services, I would think. Maybe even do a longitudinal study, which is always my goal for things, but that would be, I think, a really strong indicator. And there are different, I don't remember all the names of the assessments, but there's, sort of the resiliency, quality of life, mental health focused assessments that could be utilized to show if there's any improvement in perceptions. There, that's more client report, but I think it still holds a lot of water looking at client perception of their mental health.
Great, thanks.
In the business model for this, I guess if we're thinking, about trying to promote these programs locally, either through expansion or new startups, are there significant cost barriers to getting a program started once they're fully kind of operational? Are they operating financially well with just their kind of fee-for-service model, or do they operate at a loss and need that type of additional grant support to keep them sustainable? Just kind of generally, I guess, what are those barriers or things that we as mental health boards should be thinking about on the financial side of promoting and expanding these types of programs?
My gut understanding, not having run one, but just talking with organizations, that ramp up period where you're paying the clinicians essentially to develop the program model and to do the marketing and recruitment and the relationship building with either hospitals or schools or wherever they're receiving their referrals, that on-ramp could potentially be pretty expensive for the organizations. I know that's where we've invested money. I think McHenry County did the same thing working with Amita or Alexian Brothers or whatever they're called now. But I think they did the same thing in McHenry County, which is funding that on-ramp. But there might be other things I'm not sure.
I agree. I think that one of the struggles is sometimes when it is low census, or when it is when you don't have a full program, making the we don't do fee for service for our clinicians who are in the program. We do have FTEs. So for our full-time employees, we have to really make sure that they're staying busy and working all the hours they need to work in order for us to justify that they are, we're requiring their need. You know what I mean? I think that with a lot of PHP and IOP programs, it can be done correct and be a great moneymaker. In all honesty, but there are times where there's been a lot of hospitals where they've started the programs and haven't been successful. And I really can't speak on what's made them successful versus not successful. But it could go either way without a strategic plan.
And that's also assuming that you have the space available as well. I think space can be a barrier if you're having different types of groups and people to move around during the day. So that would be hurdle number one. Other thoughts or questions? Or meows? Any meows from Lynn?
You're funny. Thank you all.
Yeah, thank you for your time today. And, Julio, I know you're coming in and as a guest, and we appreciate you being with us today. And certainly you're welcome to stay on. I don't know if anybody else wanted to for a couple more minutes, since we have time to discuss any of the information that we're hearing from the state on the task force selection. I can speak a little bit to what I've heard just from the Region 1 task force, if anybody's interested in that. Okay.
Well, thank you guys. If you guys have any other questions, just reach out to me. Cheryl has my information, and Jenny,
Thank you so much.
more than willing to help you guys out.
Thank you so much.
Thanks, Julio. Take care.